Good afternoon. My name is Michelle McGilvery, and today I will present my Doctor of Nursing Practice project titled Clinical Practice Guideline to Improve Schizophrenia Spectrum Treatment Adherence. This quality improvement project addressed medication non-adherence and the underuse of long-acting injectable antipsychotics in outpatient psychiatric practice. The project focused on developing an evidence-based clinical practice guideline and evaluating its quality and suitability for future implementation. Committee. I'd like to acknowledge the individuals who supported the development and completion of this project. My committee included my DNP project chair, my second reader, Nursing 707 faculty member, and my community member. I am grateful for their experience, feedback, expertise, and guidance throughout this project. I would also like to recognize the clinical practice site leadership and the psychiatric mental health nurse practitioners who participated as guideline appraisers. So background and significance of the project. Schizophrenia spectrum disorders are chronic and severe psychiatric illnesses that affect functioning, quality of life, physical health, and life expectancy. Medication non-adherence remains one of the most significant barriers to successful treatment. Approximately half of individuals with schizophrenia experience medication non-adherence, which increases the likelihood of symptom recurrence, psychiatric hospitalization, suicide risk, and healthcare utilization. Although long-acting injectable antipsychotics can reduce some of the problems associated with daily oral medications, they remain underused. At the project site, there was no standardized guideline for assessing, initiating, administering, monitoring, or managing LAI therapy, creating an important organizational practice gap. Project aim and clinical question. The aim of this project was to develop and calculate an evidence-based clinical practice guideline that could standardize the outpatient assessment, initiation, administration, monitoring, and management of long-acting injectable antipsychotic therapy for individuals with schizophrenia spectrum disorders. The clinical question guiding the project was, among individuals with schizophrenia spectrum disorders, do long-acting injectable antipsychotics compared with oral antipsychotic medications improve treatment adherence after initiation of antipsychotic therapy? The project did not implement the guideline or measure patient outcomes. Instead, it established an evidence-based and methodologically evaluated resources to support future implementation. Evidence search strategy. A structured literature search was conducted using Ovid and Medline. The search was limited to evidence published from 2019 through 2025. Search terms included schizophrenia, schizoaffective, LAI, antipsychotic, adherence, and then relapse, persistence, and combinations of those. Inclusion criteria emphasized peer-reviewed English language studies involving adults with schizophrenia spectrum disorders, randomized control trials, cohort studies, observational studies, and other relevant comparative research were considered. The search initially identified 261 records. After narrowing and screening, 136 records remained. 17 articles received more detailed review, and 10 studies were included in the final evidence synthesis. Review of the literature. The literature consistently supported several benefits associated with long-acting injectable antipsychotics. Medication-related outcomes included improved adherence, greater treatment persistence, and reduced discontinuation. Clinical outcomes included lower relapse risk, fewer psychiatric hospitalizations, and in some studies, improved quality of life. Economic findings suggested that higher medication acquisition costs may be offset by reductions in emergency care, hospitalization, and overall healthcare utilization. However, the literature also identified important barriers, including stigma, fear of injections, patient preference for oral medication, provider knowledge gaps, concerns about autonomy, reimbursement issues, and the absence of standardized workflows. These findings directly inform the content of the guideline. Theoretical framework. Kurt Lewin's force field analysis guided the project by providing a structured way to identify forces supporting an opposing organizational change. Driving forces included strong evidence supporting LAIs, leadership interest, the desire to standardize care, and the potential to improve adherence and reduce relapse. Restraining forces included provider unfamiliarity, patient stigma, fear of injections, workflow demands, training needs, reimbursement considerations, and logistical barriers. Recognizing these forces influenced the guidelines' development by ensuring that it addressed not only medication selection, but also education, shared decision-making, monitoring, documentation, and future implementation needs. The goal was to strengthen the driving forces while reducing the influence of anticipated barriers. Project design and methods. This project used a descriptive quality improvement design focused on guideline development and expert evaluation rather than clinical implementation. The design was selected because the organization first needed a standardized evidence-based resource before introducing an LAI service or measuring clinical outcomes. Evidence from the literature was synthesized into recommendations addressing patient assessment, shared decision-making, baseline laboratory testing, medication selection, initiation procedures, oral overlap, monitoring, adverse effect management, and adherence assessment, and last of all, documentation. The completed guideline was then independently evaluated by clinical experts using the Agree-To instrument. This approach allowed the project to assess whether the guideline was sufficiently rigorous, clear, applicable, and appropriate for future use. So, setting and ethical considerations. The project was conducted within a private outpatient psychiatric practice with locations in Peoria and North Phoenix, Arizona. The practice serves pediatric, adult, geriatric, and veteran populations and participates in VA community care. Because this was a quality improvement project involving guideline development and provider appraisal, no patients were recruited and no patient-level information or protected health information was collected. A site IRB review was not required because there was no patient involvement. A formal letter of permission to conduct the project was obtained from the practice owner, who was also the clinical director and a PMHNP as well. Marysville University's required project review and approval processes were completed before the project activities began. So, sample. The sample consisted of 3 psychiatric mental health nurse practitioners who were appraisers employed within the clinical organization. 2 participants served in PMHNP roles, and 1 served as the owner, clinical director, and PMHNP. Each appraiser had more than 10 years of registered nursing experience before entering advanced practice. Their PMHNP experience ranged from approximately 2 to 8 years. The appraisers were selected because they represented the intended clinical users of the guideline and possessed relevant experience in outpatient psychiatric medication management. All 3 independently reviewed the guideline and completed the Agree-To appraisal without discussing their ratings with one another. Data analysis. Quantitative analysis consisted of calculating standardized scores for each of the 6 agreed-to domains, according to published scoring procedures. Descriptive statistics were appropriate because the project involved only 3 expert appraisers and did not include a comparison group, intervention group, or patient-level outcome variables. Inferential statistical testing would not have been meaningful for this design. Qualitative data consisted of written stakeholder comments. These comments were reviewed for recurring themes related to clarity, organization, clinical relevance, comprehensiveness, applicability, and recommendations for future refinement. Together, the quantitative scores and the qualitative feedback provided a more complete evaluation of guideline quality. And here is just a slide showing the number of items under each domain, also showing that domain 3, rigor of development, was a very large chunk of the evaluation completed. So results, and this is of the agreed-to domain scores. The guideline received high scores across all 6 agreed-to domains. Scope and purpose received the highest score at 100%. Clarity of presentation received 98%. Rigor of development and applicability each received 97%. Stakeholder involvement received 96%, and editorial independence received 92%. Although editorial independence was the lowest scoring domain, it remained within an excellent range. Overall, the narrow range of scores from 92% to 100% demonstrated consistently strong performance across the instrument rather than strength in only 1 or 2 areas. These findings indicate that the guideline was viewed as methodologically sound, clearly presented, clinically relevant, and suitable for future implementation planning. Interpretation of the domain scores in the analysis of results. So the domain scores provide more information than a single overall rating. The 100% scope and purpose score indicate that the guidelines, objectives, clinical questions, and target population were clearly defined. The 98% clarity score reflects specific, understandable, and identifiable recommendations. The 97% rigor score supports the systematic evidence search, evidence synthesis, and transparent recommendation development process. The 97% applicability score suggests that implementation barriers, facilitators, and practical considerations were adequately addressed. Stakeholder involvement at 96% indicates that relevant intended users participated in the evaluation, and editorial independence at 92% suggests minimal concern regarding competing interests or inappropriate influence. Stakeholder feedback as part of the overall findings. In addition to the domain scores, all 3 appraisers assigned the guidelines the highest possible overall quality rating of 7 out of 7. All 3 also recommended the guideline for clinical use and implementation. Stakeholder comments described the guideline as evidence-based, comprehensive, well-organized, practical, clinically relevant, and easy to follow. Feedback supported its potential usefulness in standardizing outpatient LAI care. Suggestions primarily involve maintaining the guideline through periodic evidence updates and considering broader implementation in additional outpatient settings. The qualitative comments were therefore consistent with the quantitative ratings and provided additional confidence that the guideline was acceptable to its intended users. Strengths and limitations. Several strengths enhanced the credibility of the project. These included a structured evidence review, synthesis of current peer-reviewed research, development of comprehensive clinical recommendations, use of the validated agreed-to instrument, and independent appraisal by experienced psychiatric providers. However, limitations must also be acknowledged. The sample included only 3 appraisers, while agreed-to literature generally recommends at least 4 to improve appraisal reliability. The project occurred within one outpatient organization, limiting generalizability. The guideline was not implemented, and no patient adherence, relapse, hospitalization, satisfaction, or cost outcomes were measured. The findings therefore support guideline quality, and they do not yet demonstrate clinical effectiveness at the project site. Discussion. The clinical question asked whether LAI antipsychotics improve treatment adherence compared with oral antipsychotics among individuals with schizophrenia spectrum disorders. Based on the synthesized evidence, the answer is yes. Although results may vary according to patient characteristics, medication type, setting, and study design. The project's direct outcome was not a measured improvement in adherence, but the successful development of a high-quality guideline grounded in that evidence. High agreed-to scores and unanimous stakeholder recommendations indicate that the guideline is methodologically credible and acceptable for future implementation. The project, therefore, addressed the organizational gap by creating the structure needed to move from inconsistent practice towards standardized LAI assessment and management. Implications for nursing practice. The project has implications for organizations, providers, patients, and the nursing profession. At the organizational level, the guideline can support consistent workflows, documentation monitoring, and quality expectations. For providers, it offers a practical evidence-based resource that may increase knowledge, confidence, and consistency when discussing and managing LAI treatment. For patients, future implementation may promote informed decision-making, shared decision-making, that is, continuity of care, adherence, and earlier recognition of adverse effects or treatment barriers. For nursing practice, the project demonstrates the role of the DNP-prepared PMHNP in identifying practice gaps, appraising evidence, developing clinical standards, engaging stakeholders, and leading system-level improvements. Conclusions and future directions here. The project successfully developed and evaluated an evidence-based clinical practice guideline for the outpatient management of long-acting injectable antipsychotic therapy among individuals with schizophrenia spectrum disorders. The guideline received excellent scores across all agreed-to domains, the highest overall quality rating from every appraiser, and unanimous recommendations for use and implementation. The next step would be a phased implementation pilot that includes provider education, workflow development, documentation tools, and ongoing support. Future evaluation should measure provider adherence to the guideline, patient medication adherence, treatment persistence, relapse, hospitalization, satisfaction, adverse effects, and healthcare utilization overall. So multi-site evaluation could also strengthen generalizability. Personal reflection. The DNP program strengthened my ability to move beyond identifying clinical problems and toward creating structured, evidence-based solutions. Through this project, I developed greater competence in literature appraisal, quality improvement, guideline development, stakeholder engagement, data analysis, and scholarly dissemination. I also gained a deeper appreciation for the complexity of organizational change and the importance of addressing both the clinical evidence and the practical barriers that affect implementation. Personally, this project reinforced my commitment to improving care for individuals with serious mental illness and increased my confidence in serving as a clinical leader and change agent within psychiatric practice. References. The next 2 slides contain the complete APA-formatted references for the sources cited throughout the presentation. The evidence supporting the project included research addressing adherence, persistence, relapse, hospitalization, quality of life, and healthcare utilization, as well as foundational sources for the agreed-to instrument and Lewin's force field analysis as a framework. And this is my final slide. Thank you for your time and attention. I would also like to again acknowledge my committee, clinical leadership, stakeholders, colleagues, and family for their support throughout this process. I welcome any questions regarding the evidence review, guideline development, agreed-to evaluation, findings, limitations, or plans for future implementation. Again, I thank you very much.